just to provide some background on our work, we all know that insurance is important, and we really chose to study it because we know that lack of health insurance across medical disciplines leads to worse access as well as outcomes, including higher rates of mortality, worse clinical trajectory. Patients are also subject to catastrophic health expenditures, and this can impact the hospitals at which they're treated as well. And there's also limitations in how patients can access post-discharge resources and preventative care. So despite the ACA, since 2016, about 15% of the US population remains uninsured. And then there was recently a spike in uninsured people given job loss and loss of employer-based healthcare coverage related to COVID. So we really felt that this was a timely problem and that there's an urgent need to identify programs targeted at acquisition and sustainment as well of insurance coverage for vulnerable populations. In our research, we identified a program that's not often talked about called Hospital Presumptive Eligibility. This is actually a hospital-based emergency Medicaid program that was enacted with the Affordable Care Act and implemented across all states. So the way this works is that uninsured patients at the time of hospitalization are screened by financial counselors or social workers, and then potentially approved for temporary Medicaid coverage that will last up to 60 days. And this is done in an effort to increase access to post-hospitalization care, as well as offset hospital costs. And then the real question comes after those 60 days as to whether patients go on to sustain coverage, because they're required to then fully enroll in long-term Medicaid after discharge. And there's county level officials and third-party vendors that usually contact them to assist them with this process. So we wanted to further study HPE and with this seed grant, identify key patient and hospital level factors associated with successful HPE approval, and then also understand reasons why HPE might not be approved. We also wanted to understand and determine factors that are associated with longer term Medicaid enrollment after HPE approval. It's important to understand that our current data sets are quite limited in our ability to study HPE, and this is a problem with insurance status documentation across clinical registries, administrative databases, and hospital EMR. So if you have a patient, their medical records will actually put their expected payer status at the time of discharge, and it doesn't necessarily reflect true insurance status at the time of admission, nor if there's a change in status during their hospitalization. So you could imagine during a retrospective chart review, a patient that came in uninsured, was approved for HPE Medicaid, just shows up as Medicaid, and it's impossible to differentiate them from somebody who maybe had Medicaid insurance for years. So with the funds from this seed grant, we were very fortunate to partner with the state of California and specifically the Department of Healthcare Services, who agreed to create a customized novel insurance data set for us, which really will contain all HPE beneficiaries in the state of California and allow us to longitudinally track their claims in order to determine when patients, whether patients actually enroll in full Medi-Cal after their HPE period. And then they also will be linked to hospital annual financial disclosure reports to describe characteristics of facilities that are enrolling these types of patients. So our goal is really to identify or measure the success of HPE programs and find out opportunities at the patient, hospital, and state level. So I'll pause here and just say that we haven't received the entirety of this data set yet due to delays regarding COVID at the state level. The data that I'm going to be presenting is aggregate patient data, as well as some of the hospital level data that we've been able to work with so far, and we'll be receiving in the coming month or so the individual patient level data that I described that will allow us to longitudinally track. But we see that fortunately, there's been a steady increase since 2014 in the number of HPE approved patients in California, but it still remains just a small fraction of the total number of uninsured patients. So there's definitely an opportunity to increase awareness about this program and perhaps broaden the scope of eligibility. And you also see shaded in pink is there's significant variability in the number of applications per month, and that suggested to us that there may be some variability around holiday timing, and then also due to staffing and personnel issues, either at the hospital level or the county level where these applications are processed. We were able to use the financial disclosure reports of the hospitals to determine that there's actually a significant positive financial effect associated with HPE participation. So the traditional model in hospitals where they don't participate in HPE is that uninsured patients' services end up being paid by the patient themselves, indigent program funds, or it goes to the hospital to pay as uncompensated care. In patients who, in hospitals who do participate in HPE, not only the hospital services, but post-discharge services for up to 60 days can be paid by Medicaid. So we identified that HPE enrollment across all hospitals was associated with about a 10% increase in annual net patient Medicaid revenue, which was about $6 million annually. And this is some work that was published in Medical Care that I collaborated on with Todd Wagner, one of our health economists, as well as DM Tran, who was our postdoc at the time and is now full faculty at the VA. We also looked at geographic distribution of HPE participating hospitals. So we have these heat maps for all regions of California, but this is just an example of the LA area. And you see that HPE hospitals are in purple, non-HPE hospitals are in blue, and then the size of the circle, it sort of correlates to bed size. And then as the green shading gets darker, is higher rates of uninsured in a particular county. So not surprising that hospitals in zip codes with the highest rates of uninsured residents were more likely to participate in HPE. But what was interesting is that we found in certain areas, despite serving the same zip code with the same rates of uninsurance, some hospitals that were very similar in size and ownership had discrepancies in whether or not they participated in HPE. So this is something that we plan to study further with qualitative interviews. Looking at our regression for likelihood of HPE participation, we see that it was significantly correlated with bed size. So it makes sense that larger tertiary referral hospitals are more likely to participate in these programs, as well as safety net hospitals whose main mission is to serve the underinsured and the indigent. And we were very interested to see that there was a strong correlation with participation in trauma centers, which actually led to another part of this study at the local level in our own trauma center to sort of identify reasons why this is so important. So we know that trauma patients are disproportionately impacted by lack of insurance, and they're actually 2 times more likely than the general population to be uninsured, and very high likelihood that it'll be financially catastrophic for these patients. It's been quoted in the literature that up to 90% of uninsured patients can actually be subject to catastrophic financial injury after trauma. And many of our trauma patients often need access to post-discharge services, making insurance all the more important. So rehabilitation, prescription medicines, mental health services, et cetera. Sufu recently presented some work on insurance churn, and she'll be presenting this as well at our national trauma meeting in the fall. But she found that even among private payers, there's a very high rate of insurance churn within the first year of trauma. So what we did was do a local study while we're waiting for our state level data of our Stanford trauma registry and EMR for the past 4 years, which involved a very extensive review of financial counselor and social worker records to determine who was approved for HPE and who was not. This looked at adults in Medicaid eligibility age 18 to 64 with a primary diagnosis of trauma. And the work here that I'll be quoting was published in the Journal of Trauma and presented last year at our trauma conference by one of our surgical residents, Josh Jaramillo. So we looked at about 2,000 patients, 946 of which came in uninsured at the time of injury. We actually did quite well at Stanford, and there was an 86% screen rate. That's fairly decent if you think about all the patients that come in as traumas overnight and that are discharged from the ED within a few hours and probably didn't have an opportunity to get screened. However, only half of those actually were approved for HPE by the time of discharge. So we saw that that was partially related to not being screened, but then there were actually a majority of patients that were screened but not approved for HPE. So we wanted to understand why that was. Just a couple of quick slides on characteristics of HPE approved patients. So they were more likely to be younger males of racial and ethnic minorities, understandably more likely to have a significant injury or major trauma, which resulted in longer inpatient stay, usually ICU admission, operative intervention, and length of stay in the hospital and discharge to post-acute care. In mixed effects regression, the main things that really stood out were the sociodemographic characteristics that merit further qualitative study as to reasons why, as well as injury severity scores being a huge driver for HPE approval. When I talked about trying to identify some of the reasons why HPE might not be approved, this was what we found at Stanford, and it'll be interesting to see what this might be at a state level as well. So we mentioned the 14% of patients who didn't get screened ultimately, but there was actually about a third of patients who were identified as being over the income threshold for being approved for HPE. And surprisingly, 1/4 of patients actually refused insurance, or they left the hospital AMA, or they left the hospital and subsequently were unable to be contacted to follow up regarding their application. There's understandably a few people who were non-residents and visitors traveling who weren't eligible for the program, and then a small percentage of people who had already had HPE once within the previous 12 months, which is an exclusion criteria for the program. They only do one approval per year. And then there's some assorted miscellaneous reasons why, citing technical issues with the application system electronically, or patients falsely claiming insurance coverage, so they didn't get an appropriate workup. It's interesting to note that with COVID, they recently expanded the eligibility criteria of HPE. So now they relax the income threshold and allow you to have multiple HPE approvals per year. So it'll be promising to see that hopefully more patients will be captured by this program. So some of our preliminary conclusions are that really the time of hospitalization is not often talked about when we talk about insurance, but it's an underutilized opportunity for intervention. And HPE could potentially help patients acquire Medicaid coverage at the time of hospitalization and sustain it if we have the appropriate education surrounding it. And we also identified some promising individual hospital and policy level opportunities to increase HPE acquisition, such as improving financial counselor screening, patient education regarding insurance, as well as relaxing some of the income threshold policy requirements. So these all merit further study across California as well as nationally. And I think there's also a very interesting opportunity to more accurately capture insurance data within our own clinical registries that would facilitate future study mitigating socioeconomic and insurance disparities. So some of our next steps, we're doing ongoing local patient and provider and personnel interviews here at Stanford to understand the successes and limitations of the HPE program. And we're fortunate to have a Med Scholar student who will be joining us this summer to complete some of this work with us. And then once we receive the full extent of our state data, we'll be able to understand the HPE patterns across clinical disciplines, not only trauma, and this will facilitate longitudinal study of factors influencing Medicaid enrollment or insurance dropout after the HPE period. Dr. Morris mentioned that we were able to submit an R21 with some of this preliminary data last October, and we're planning for a future multi-center R01 that'll look at national HPE patterns among trauma patients. So I just want to conclude by saying thank you to the department for this seed grant and for the opportunity to present the work. And as you can see, it truly does take a village to do this type of work on not only partnering with the state, but Dr. Morris and her amazing team at Aspire, some of the health economists, statisticians, and social scientist researchers that I've worked with, as well as Dr. Spain and some of our general surgery residents, Sue Fu and Josh Jaramillo, and our Med Scholar student, Anna Carolina, who will be coming in this summer, as well as all of the trauma nursing staff that have also helped with this project. So thank you again.